blood pressure measurement, to estimations based on the EHR that you are likely to have hypertension based on your social demographics, plus some things about your race, ethnicity, plus now you have to be careful, you don't want to create biased populations and you don't want to target populations. But I think there are so many different ways to identify patients at risk. That's not the part. The part is then figuring out how do we create a well-regulated and compensated structure to then deliver healthcare to those patients remotely and even titrate their medication, their treatment safely. Because there's hypertension that's up here, that's dangerous, and yeah, you need the doctor, you need to be in the office. And then there's just about everybody else who has mildly elevated blood pressure, but we're letting it go on forever, and therefore dialysis rates, which is the most expensive thing we do, are high, and strokes, and coronary disease, and like you name it all comes from hypertension. So what does a relatively closed loop look like for diagnosis, assessment, in some virtual way, and then deciding to go ahead and treat those patients and adjust things without bringing those patients into the office, without doing the current RPM codes where like, my staff used to calculate, no, it's been 15 days, doc, you need one more day before you can charge for this and do it. It just doesn't make any sense. So what is kind of a comprehensive outcomes-based payment structure with a good regulatory structure look like? That's, I think, something that we could do at a national level, and our base can do it alone, right? It requires the FDA. Oh, sorry, I'm the chair of the Digital Health Advisory